from the initial team actually was to possibly repeat an ultrasound at a later time, given that the patient was comfortable in the moment, to see if there might be a difference if it was repeated. But I think the no flow does raise concern for torsion and lean you toward going for laparoscopy.
All right, well, we're going to have to stop here. Ray, thank you very much for an excellent job. Two very interesting cases, so thank you.
Thank you.
All right, so in just a minute, I'm going to ask Dr. Phillips to introduce our grand round speaker. But in the meantime, with regard to attendance, we'll be taking attendance by looking at the participants list and by looking around the room in MEB 102. And if you have any questions or if you're a call-in, you can email your attendance to Michelle or Beth or I. Also, with regard to the CME code, it will be distributed using the email system around 8:10. So thank you. All right, and with that, Dr. Phillips, are you ready to introduce our speaker?
I am. It is my pleasure to introduce Ashwini Korgaonkar. I hope, and I apologize. She is the senior physical therapist at the RWJ Barnabas Health in Somerset, Barnabas Health at Somerset in Somerville, New Jersey. She's a board certified orthopedic specialist who's also certified in aquatic and vestibular rehabilitation. She's pursuing a board certification right now as a women's health clinical specialist and a clinical doctorate in physical therapy from Arcadia University. On a personal note, Ashwini has been an incredible asset to our practice. She has managed to make Dr. Hutchinson's weak pelvic floors strong and my patients' strong pelvic floors relaxed. And it is amazing how the addition of pelvic floor physical therapy has been a real game changer for gynecology, for chronic pelvic pain, for all the things that she's going to talk to us about. She has an incredible bond with every patient that we send her. Her and her entire team are fabulous. We wish there were 1,000 more of them. And I am really excited for this presentation because I think there are so many applications for pelvic floor physical therapy that we have not thought of as clinicians. And I think this is a real asset to our field. So with that, Ashwini is going to talk about pelvic health physical therapy in outpatient OBGYN settings.
Thank you so much for that introduction, Dr. Phillips. I really appreciate it. I'm going to stop my video here and I'm going to start with my presentation. A second. Am I still on? Okay, stop video. Okay. All right. So thank you for inviting me to speak. I'm going to talk about introduction to pelvic health physical therapy and outpatient OBGYN setting. Okay, I have no financial interest or relationships to disclose. This is where I work at Somerset Hospital. This is our department. Objectives. So at the end of my presentation, you'll know how to screen patients for pelvic floor dysfunction. You'll understand basics of PT management in commonly seen pelvic floor dysfunctions. And lastly, you'll be able to identify various commonly used PT modalities and tools in PT management. We're keeping it simple and practical. So this is my main fourth objective, is to keep it simple today. So who are we? So we are licensed as physical therapists. We receive a specialized training in pelvic health. There are 3 levels of training which goes on increasing in complexity. Level 1 is a foundational course with training in basic topics of anatomy and physiology, also include management of simple topics like urinary incontinence. Level 2 focuses more on pelvic pain and bowel dysfunction, and level 3 includes advanced topics such as management of post-op patients, pelvic cancers, interstitial cystitis management, etc. So we are uniquely qualified to treat pelvic floor dysfunction. That's because we get trained in management of orthopedic and neurological dysfunction. We know how to treat chronic pain by using specific manual therapy skills. We have in-depth knowledge of pelvic floor anatomy and muscle physiology. Simply speaking, it's hard to find any other profession which has a mix of all these skills put together. So how do you screen patients for pelvic floor PT? Who do you think is a good candidate for pelvic floor PT? So I follow Nicole Cozine's pelvic floor dysfunction screening protocol. Nicole Cozine is a physical therapist in California, and she has done a lot of work in IC management. She is the only physical therapist on board of AUA. So she came up with this protocol in 2018, and the protocol is pretty simple. It's user-friendly and has only 10 yes or no questions, and it has a 91% sensitivity. And if 3 questions out of 10 questions are positive, then patient is likely to have pelvic floor dysfunction related to musculoskeletal system and likely to be a good candidate for pelvic floor PT. So the 10 questions include topics on pelvic pain, falling on tailbone, urinary symptoms, nocturia, pelvic pressure, orthopedic pain, bowel symptoms, pain with sexual activity, and pain or increased symptoms with prolonged sitting. The prevalence, obviously, pelvic pain is highly prevalent, followed by urinary symptoms, followed by orthopedic pelvic pain, and lastly, increased symptoms with prolonged sitting. Okay, so once you screen your patients and send them to us, what happens on first day, like first visit? So we have 60-minute sessions with all our patients. All visits are one-on-one sessions. We see patient sees same physical therapist in the same room. I feel that creates safety, routine, consistency, and trust. It's covered by insurance or charity care. Typical frequency is 1 time a week or more if needed. Usually my pelvic pain patients will see me about 16 to 12 sessions on an average. Internal exam is always with consent and can be deferred. And when I say that it could be deferred, I have to make it a point that internal exam gives us most amount of data. So please encourage your patients to participate. If you can encourage them, they're more likely to go through the internal exam with us. So examination would include external evaluation and internal evaluation. Remember, we are movement specialists. We are posture fanatics. We look at breathing. We look at general body mobility. We look at, especially look at mobility of lumbar spine, thoracic spine, hips, knees, ankle, feet, mobility of abdominal fascia, diaphragm, flexibility of the hamstrings, hip flexors, quadriceps, piriformis, palpation of superficial UGT muscles, observation of perineum. This will include the external evaluation. The internal evaluation, on the other hand, would include either transvaginal or transrectal or both if the patient has bowel symptoms. We are looking at tone, tenderness, strength, endurance of pelvic floor muscles, ability to relax and ability to contract, ability to coordinate with commands. Are they following it with squeeze and relax? If I ask them to squeeze and contract, are they contracting it? Are they relaxing it with my commands? Are they swiftly coming back to baseline once I ask them to relax? We also look at the mobility of perineal body and perineal fascia. Okay, so this is how do you measure strength of pelvic floor muscles? We follow perfect scale. The scale was developed by Laycock in, I think, 1948. The scale helps us quantify the strength and endurance of pelvic floor muscles. It helps us objectively track progress. We have a 6-point scale. 0 is no contraction, 1 is flicker, 2 is weak, 3 is moderate, 4 is good with lift, and 5 is strong. So while going through the data for preparation for this presentation, I came across this guidance document that AUG has presented in December 2021. The purpose of this document was to increase understanding of PT treatment and evaluation techniques, thereby improving communication between the practitioners. A pretty good document. All right, so in normal asymptomatic pelvic floor, there's a fine balance between mobility and stability of the muscles. Too much mobility occurs when muscles become weak or hypotonic, and too much stability occurs when muscles become too tight or hypertonic. So common indications for pelvic floor PT include under too much mobility, pelvic organ prolapse, stress incontinence. Under too much stability, you will see conditions such as IC, endometriosis, dyspareunia, vaginismus, vulvodynia, OAB, or urge incontinence. So let's talk about too much stability, pelvic pain. So treating pelvic pain in US is pretty expensive, more than 800 million per year we spend. About 50 to 90% of patients with chronic pelvic pain will have musculoskeletal pain and dysfunction. That's where PT comes into picture. Chronic pelvic pain is a very common problem and affects approximately 1 in 7 women. This slide basically talks about cycle of sexual pain. In simple manner, it talks about cycle of pain leading to spasm, more pain followed by more muscle spasm. And this vicious cycle continues and needs to be broken by using high quality education about pain and safe touch. So pain is made in the brain by David Butler. David Butler is a physical therapist out of Australia, has done a lot of work in pain science and has a lot of books out and a lot of presentations and papers out. He says that pain is made in the brain. The definition of pain is it is a sensory and emotional response with or without the tissue damage. So it's absolutely one of the most important topic in management of pelvic pain. Pain is protection from danger, and you do not want that protection to last too long. Pain leads to muscle spasm that leads to more pain, and that cycle goes on, as I said. Simple movement and high quality education about pain is found to be more effective than painkillers. So let me repeat, it's simple movement and high quality education about pain will take pain away and is found to be more effective than painkillers. So pain is created by brain when it weighs the world around it. When it senses more danger, it creates more pain. So treatment of pain then is to create more safety than danger. Nervous system. So nervous system, typically is divided into autonomic, somatic, and enteric. So autonomic nervous system has these two pathways, your sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system is responsible for emotions like anger, anxiety, fear, frustration, fight and flight responses, while parasympathetic system is all about calm, relaxed feelings, content, happy feelings, rest and digest type of situation. In our pelvic pain patients, the sympathetic system is completely, it's screaming. It's on high volume, while parasympathetic system is completely shut down. So the role of PT then becomes to turn up the parasympathetic happy system and turn down the sympathetic system. Okay, so far we looked at who PTs are, how to screen patients for pelvic floor PT. We looked at PT exam, internal versus external. We looked at common indications for pelvic floor PT. We looked at too much mobility versus too much stability situations, and then pelvic pain and pain science. Okay, now we're getting into management part of it. Sleep, nutrition, stress management, and movement. These are the pillars of pelvic health, and without addressing each one of them, I usually don't go ahead and start treating my patients. So sleep, at least 7 hours are recommended. Nutrition includes food and water. nobody drinks enough water, so usually I'll address their water intake. If they are not eating well, they're not going to feel well. So I usually address nutrition aspect of it too. Stress management, how are they managing stress? Who are their support structures? What are their stressors? Are they seeing someone for counseling? Movement, are they moving at all? Are they sitting all day playing video games or coding? Do they have any willingness to move? Do they need structure? All these questions are addressed when we see them, in first or second visit. Once you find out the barriers, you really need to know the barriers. We address the barriers, and I feel following up on them on a subsequent session. So it's extremely important to kind of have these people get their buy-in that we have. Okay. Management. So how do we treat too much stability? How do you treat pelvic pain? So I strictly have outside-in approach for that. So I usually start working on outside of the pelvic floor and gradually hone in and work on pelvic floor, maybe after 3 or 4 sessions of working on external aspect of the body. So I usually start with body scanning, relaxation, breathing exercises. They actually go through contract relax techniques where they actually actively relax their muscles and understand what relaxation means. These patients are typically type A patients, frustrated, upset personalities. So relaxation really works. And without addressing that, the outcome of your pelvic floor therapy is not that great. For pelvic pain, I heavily rely on manual therapy. I'm a manual therapist by trade, so I like to touch my patients. There's a huge power in safe touch. So when I work on my patients outside of pelvic floor, I work on their myofascial release, their diaphragm release. I do visceral mobilization, particularly bladder mobs, pudendal nerve mobilization. And once I'm done with all that, and I have patients trust in me, then I would start and go in my internal mobilization and actually start mobilizing my pelvic floor. Education on pain science, we talked about that. Behavior modification, extremely important. Biofeedback to reduce, to normalize high resting tone. So pelvic pain will have high resting tone, and once they see it on biofeedback device, they actually start working towards reducing that tone. Obviously, therapeutic exercises in the form of breathing exercises, diaphragmatic breathing particularly, and stretching and mobility exercises. We do not do strengthening exercises for pelvic pain. Okay. So the internal stretching, once I'm done with the external aspect of my mobilization, then I would go internally. And once I'm inside there, I'm going to do manual stretching. And then this patient is going to get wand for stretching at home. So this doesn't replace what PT does in the clinic. It just basically extends the gains that we receive, that we get in the session, so that they can maintain these gains at home. So pelvic wand was created, is supported by literature, gives additional length to reach deeper pelvic muscles. And it is definitely useful in conditions such as dyspareunia, vaginismus, which present with hypertonicity. Especially my postpartum patients also to mobilize their episiotomy scar, they would have the wand. So vaginal dilators. Dilators cause graded stretching due to increased length and diameter, as you can see. They work based on the concept of low load, long duration, causing long-term tissue deformation. So usually I would have my patients start with about, say, 5 to 10 minutes of this. Again, depends on their tolerance to pain. Some people do not tolerate that to begin with, and gradually the time would increase, the depth would increase, the diameter of the dilators would increase. These are the patients typically with high tone pelvic floor, especially pelvic pain, who are interested in penetrative intercourse. This can be used in different positions, supine hook line, or sitting up in the toilet, or sideline, or even quadruped with a partner. And a rule of thumb is to go one level above your partner's size. Same concept, except that it's used rectally. Okay, management of too much mobility, pelvic floor weakness. Okay, So Kegels are mindful, isolated contractions of pelvic floor. For one to do Kegels, they have to first recognize that they have pelvic floor muscles. Some people just don't know that they have pelvic floor muscles when you ask them to squeeze and lift. There is silence. There's nothing. So first job of PT is to help them recognize that the pelvic floor muscles exist. Once they recognize that, and usually takes a session or two, once they recognize that they have those muscles, then isolate them, because you don't want those muscles to work in conjunction with your abdominals, your gluteus maximus, your adductors. You want them to work in isolation. Once they figure that out, again, safe touch, proprioception, myofascial release will all help these people recognize and then isolate these muscles. Once you recognize and isolate them, coordination, are they following your commands? Some people just don't know how to relax their pelvic floor. I would tell them, okay, squeeze and lift. They'll squeeze and lift. I'll tell them, okay, now relax. They'll squeeze and lift. I'll tell them, okay, now then you bulge your pelvic floor, they'll squeeze and lift. That's all they know. So coordination is a huge part in management of these people, because they need to kind of follow. Once they follow their therapist commands, then they'll start following their own body's commands. So coordination is big part of this rehabilitation. And then once you understand how to recognize them, how to isolate them, how to coordinate with them, then the job is to just repeat them. You just kind of get better at that, just like learning to ride a bicycle, where you understand how a bicycle works, and now to get better at it, you just keep riding it. So repetition is again important part of it. So we not only do Kegels for too much mobility or pelvic floor weakness, we also work on core, hip strengthening. We use biofeedback to improve recruitment of the muscles and resting tone. We use vaginal weights. We use app-based pelvic floor strengthening devices, like playing video games with your pelvic floor. Pretty common and popular in younger patients. Okay, to Kegel or not to Kegel. So in general public, there is this understanding, or rather misunderstanding, that Kegels is what pelvic floor therapist does. And it's absolutely not true. Pelvic floor therapist does way more than just doing Kegel exercises with the patients, as you are seeing and will see. Kegel exercises are not synonymous with pelvic PT. It's merely one of the tools in pelvic PT's toolbox. Again, the definition of Kegel: isolated, mindful contractions of pelvic floor muscles. Indications are low tone, low strength, low endurance, and contraindication is pelvic pain. Absolutely no Kegels in pelvic pain. And again, isolation is the key. Okay, vaginal weights, developed in 1985 to increase awareness of pelvic floor muscles. You can see the progression from 25 grams to 125 grams. The color gets a little darker. They're like weighted tampons, simply speaking. I have patients do Kegels with them inserted as a progression. Patients can start in supine, then go to sitting, then go to standing, then go to walking, and finally go on stairs. Recommended to use no more than 15 minutes a day, and this is how you insert it. There's a tail that hangs out, so you can easily pull them out. Pretty easy to use. Indications of vaginal weights are, again, low tone, low proprioception, low motor awareness. Patient population that gets benefited by it is low-grade prolapse patients, incontinence patients, and postpartum patients. Contraindications would include severe vaginal prolapse. We're talking like grade 4, severe vaginal dryness, severe vaginal atrophy. The weights just simply fall out with vaginal atrophy. And again, pelvic pain patients, you're not using vaginal weights. Constipation. Constipation is a huge topic, and I'm just going to scratch the surface of it. Constipation is extremely common amongst all ages. In the United States, 16% of adults over 60 have constipation symptoms, and the percentage increases to 33% in adults over 60 years of age. Okay, so we have slow transit constipation or normal and normal transit constipation and dyssynergic constipation. So PT management for slow transit and normal transit pretty much the same, differs a little bit with dyssynergic constipation. So education is the mainstay, making sure that their nutrition and their water intake is assessed. Are they eating enough fibers? Are they eating processed food? Are they drinking enough water? Are they moving? Are they sitting all day long? All these things are important. Posture on the commode is, I think, really we work on it and kind of address it with the patients. This green man is sitting leaning forward a little bit, and that angle of leaning forward, what that does is it kind of relaxes your puborectalis. Your puborectalis starts from your pubis, hangs around your rectum. So when you lean forward, you're actually slacking it. So when it's slacked, your rectum is not kinked, and there's like a straight shoot of poop into the toilet. Small stool definitely helps to bring your knees up over your hips. I'll go back a little bit. So dyssynergic constipation occurs when there is a discoordination or incoordination of abdominal and pelvic floor muscles to evacuate stools. Now, commonly in clinical practice, I see that it's usually your puborectalis and your EAS. So rectal stretching, rectal rectal fossa release usually does the trick, along with education and posture on the come up. All right, so clinical practice guidelines for management of constipation. So Academy of Pelvic Health Physical Therapy came out with clinical practice guidelines for management of constipation in 2021. They found overwhelming evidence for use of biofeedback, manual therapy, electrical stimulation in form of transcutaneous tibial nerve stimulation. Biofeedback, we're going to talk in detail in next slide. Manual therapy will include abdominal fascial release, colonic massage, the I love you massage, ischiorectal fossa release, release of levator ani muscles. Like I said, puborectalis, and then your ischiorectal fossa has your EAS. So physical therapists usually kind of hone in there just to improve that dyssynergic constipation. Obviously, therapeutic exercises will include stretching exercises. You don't want to strengthen yet. You want to stretch first. And then urge initiation exercises, which basically include like twisting, rotation type of exercises to improve colonic transit time. Okay, biofeedback, this is how it looks. Nothing much to look at. Your vaginal and rectal sensor. We have this device in the department. This is very commonly used device. Easily available, easy to hold. Patient usually holds this in their hands and kind of works on their tone or strength with PT's guidance. Okay, so biofeedback can be done with surface electrodes versus vaginal rectal electrodes, the internal electrodes. The ones that I showed you, these are examples of internal electrodes. There are surface electrodes that go around your anus, usually around like perianal area. I personally don't like to use surface electrodes because they pick up a lot of noise from big muscles around, like your gluteus maximus medius. They'll pick up a lot of data from those muscles instead of like internal pelvic floor muscles. So I usually go for vaginal rectal internal electrodes. The important thing about biofeedback is to understand the resting tone. So once I insert the internal electrode, I would wait for about a minute, and then it'll start showing me their resting tone. Typically, patients with hypertonia, like pelvic pain, would have resting tone way more than 2 millivolts. They'll be like in 7, 8, or in 10s, while the person who has hypotonia, weakness of pelvic floor, would show me, range of 1.1 or 1.2, sort of like really low numbers. I have this diabetic patient that I'm treating, uncontrolled diabetes with diabetic neuropathy. His resting tone is like 1.1, and working hard on getting that going. So what biofeedback does is it basically objectively measures your endurance and strength. So it's one thing therapist telling patient, oh, your muscles are not strong enough, or you're not holding your contraction long enough. Now they have these numbers and this data to go by. And once they have it, they usually hold it in their hand, and we sit next to them and kind of guide them into either reducing their tone or increasing their tone. Role of pelvic floor PT in 4th trimester postpartum patient. All right. So these are common postpartum issues and its management. Usually used on the top bladder or bowel issues. These issues will mostly present like hypotonia because of childbirth. The pelvic floor is just weak. So it has decreased strength and tone, and we talked about how to manage it. We manage it with Kegels, vaginal weights, core strengthening, hip strengthening, pelvic pain literature supports use of physical therapy, stabilization exercises with pelvic belt. We came up with clinical practice guidelines to treat pelvic pain, low back pain, suffices pubic pain in postpartum patients. And it basically talks about exercises to stabilize your pelvis and use of pelvic belt. Then you have abdominal weakness and diastasis recti. Again, stabilization exercises with abdominal binder would be a good way to start. This binder is to bring two ends of your rectus together and then strengthening your abdominals. Postural dysfunction, these new moms are practically at home, feeding the baby, picking up the baby, just taking care of the baby. So their postural dysfunction would include excessive thoracic kyphosis, like bent forward posture. Sometimes they'll present with that lumbar lordosis too. So management would be stretching the front part of your chest, like your pectoralis minor, your major, just doing doorway stretches, and strengthening your scapula, your thoracic spine, just to kind of bring that patient out of that thoracic flexion. Poor endurance. I mean, this is very commonly seen. These moms have not done much in the last 3 months of their pregnancy, and then now they have a baby on hand. They are hurting. They're going through all these other complications. So they don't want to move. So poor endurance is definitely commonly seen. I just usually get them moving. I just put them on the treadmill, give them structure, tell them, 20 minutes a day, 10 minutes a day, start walking, to start moving a little bit. And once they start doing that, within 6 to 8 weeks of PT, their endurance usually, returns back to where they were before. And lastly, your sexual dysfunction. Now, sexual dysfunction is present mainly because of vaginal dryness, the hormone changes, and then there is this pelvic pain because of episiotomy. They're healing from that. Usually managed by manual therapy, pelvic wand, as we discussed, and then application of lots of lube. Usually corrects itself within like first 3 months of postpartum. Okay, so it takes a village. I'm going to bring you home with my last slide. It does take a village. It's not only about PT or physicians, it's about everybody else who can do wonders for these patients. Mental health professionals, acupuncturists, yoga teachers, nutritionists, all of them have a very important role to play. These are my references. There are many more. I just didn't want to put too many slides with references. If you want to know anything, you can always reach out to me. And if there are any questions, I can take those.
All right, thank you. Thank you so much for that excellent review. We already have a question in the audience from Dr. Ayub. Go ahead.
Hi, good morning. Thank you so much for a great talk.
Thank you.
You mentioned episiotomy a couple of times. I'm wondering if you find similar or overlap between patients who've had lacerations that occur on their own, like second-degree lacerations, and patients who've had episiotomies in terms of their pain and the treatment that you use.
So PT management, I'm just trying to start my video. Hold on for a second. Okay. So PT management is not going to differ much as far as the laceration or episiotomy is concerned. We are looking at the quality of the tissue. We are looking at the mobility of the tissue. So if it is episiotomy or laceration, the management is going to be pretty much the same. They usually come to us at 6 weeks postpartum, 6 to 8 weeks, I would say. And by that time, the scar has healed a little bit already. And management wise, we'll just start with like, using the lube, using sometimes lidocaine helps to kind of get the pain down a little bit and have that fear go away. And then manually mobilizing with my finger, going in there, just kind of global stretching in that area usually helps. I don't know if that answers your question.
I see that Dr. Lizer has her hand up.
Thank you. Great talk. I had more of a logistical question. For our gynecologic oncology patients, we've been referring to Kessler for pelvic floor physical therapy.
Okay.
And we even collaborated with them on some papers. I was not aware that this was available at Somerset. Can you just go through some of the logistics and how you see patients and where you see patients and how to refer?
Okay, sure. So I hope that you use Epic. Do you guys use Epic?
Yes, we do.
Okay, good. So in Epic, you can put the referral in for pelvic PT, and then select SAM PT. That's our location here. We have 4 physical therapists. It's me, including me. It's Ashwini, Aparna, Deborah, and Danielle Vadiker. So all 4 of us. It's kind of unusual to see 4 physical therapists working together in one. Usually, people have like 1 or 2 therapists working in isolation. Remember, we don't have too many pelvic floor PTs in this field because you'll see more orthopedic PTs than pelvic floor PTs because of the extra education and sensitive nature of this profession. So 4 of us are here. We start seeing patients at 7:30 in the morning. Our last patient is at 5 o'clock. So it's pretty much whole day is covered. It's 60-minute session, one-on-one, like we discussed. Once we get the prescription, our front desk, once you put the referral in Epic, our front desk will reach out to the patient. You can give the information yourself to the patient and have the patient call us too. If the patient has questions, I usually on a daily basis take questions from patients who have like queries about what I'm going to do or the nature of therapy. I do that. If they have questions, I'm more than happy, or any member of my team will be able to take those questions and talk to the patient and make the patient comfortable before they come in. Once they come in, it's usually 8 sessions to start with. And depending on what they have, they either can go less or more. Usually hypertonic patients, weakness patients, my older ladies usually are better in 8 weeks, depending on what they have. Pelvic pain patients will take a little longer, about 12 to 16 sessions. But all 4 of us are highly trained. We know exactly how to treat different types of dysfunctions. So even if I'm presenting, if one of my team members was presenting, they would have the same approaches towards these dysfunctions.
Thank you. Where are you physically located?
So we are in Somerville location. It's Somerset campus of Robert Wood Johnson. So we are not that far. We're like 20 minutes away from where you are, actually. So the other thing that I want to point out is we used to have locations in Old Bridge. We used to have location in East Brunswick, New Brunswick. When I was there, this was like 5-6 years ago. All those locations have closed. And then this is the only location that we have here that does pelvic floor physical therapy in Central Jersey. Now, the reason it's important is because we take charity care patients. I don't think Kessler would take charity care patient from Robert Wood Johnson. We take Medicaid. I think Medicaid patients need to be associated with hospital-based PT. And pretty much any insurance under the sun. So please have if you can channel these patients over to us, would be great.
And one quick follow-up
you.
question, your evaluations and the data, I'm just thinking for looking at this, and seeing how our patients do potentially for a research type protocol, that's all within Epic, your notes, your charting, your quality measures are all within the Epic system and trackable?
Absolutely. I mean, we can read your notes and you can read our notes. We have all this data available from your side, and you have all that data available from our side. So yes, and that's the beauty of Epic, that we can, especially, I mean, reading your notes before the patient comes in is so helpful, because it kind of gives us little background before patient comes in, and we rely heavily on that.
Thanks so much.
Oh, absolutely.
I see that Dr. Phillips has a question.
Thank you, Ashwini. That was wonderful and gave us so much more insight. I have a couple comments and then a question.
Okay.
My comment is that I love your whole body approach, and I think that especially in the pain patients, a whole body approach is really, really important. Sometimes the resources for whole body approach is difficult. So if you have any resources for the acupuncturists who are interested in this, that would be a great help to us, especially for acupuncture. For some of the other components, we
Right.
have some help finding that.
Right.
But then can you, for the learners, for those of us who don't do as much pelvic pain or vulvodynia, do you have like a quick way to describe how we can do an exam to assess muscle tone in our limited time with a patient?
Okay, I mean, so I can talk to what we do. So when we, as a physical therapist, I'm looking at the muscle physiology aspect of it, right? So that muscle physiology would include the endurance and the strength, along with the tone of the patient. So the tone of the pelvic floor. So for us to, it's kind of hard. So we know what normal tone is, and I'm sure you know that too. Like it's more for a subjective understanding of what normal tone feels like versus what high tone and low tone feels like. So if there is higher tone, I usually look for if there is any tightness of the fascia, or are there any trigger points that's causing that higher tone? Is there any bladder dysfunction or urethral dysfunction? Are there the muscles pulling the urethra in either direction? Like there, for tone purpose, there has to be a reason why the person has high tone. So usually I look for, what is the reason or cause of it. Once I find the cause, let's say trigger point in coccygeus is the cause, or puborectalis is the cause, then the management becomes to release that and see if there is any change in the tone. So as a practitioner, it's kind of hard. I usually compare both sides. Sometimes people have normal tone on one side compared to the other side, and that becomes like, that'll give me some clinical indication that, okay, fine, this side looks a little bit more, upset or angry type of thing. And then, so comparing both sides would be helpful. I guess, is that enough of an answer? I don't know. I feel it's so much more subjective than.
Right, I know that I know it's difficult, but I think it's important for, the learners to remember that when you're doing your pelvic exam or when you're doing your bimanual, that you're not just going straight to the cervix, right? That there's
No.
structures along the way, there's side walls, there's anterior walls, and that's really important. One
Right.
sign that I always find for my high tone patients is if I can only get one finger in and I can
I know.
so on the bone at the same time.
So
I can touch the anterior bone and the muscle at the same time. That means pretty much high tone to me. Is
Right.
scale, like the 0 to 5 scale for muscle strength, it is for high tone, it just the opposite of that.
Can you repeat that question? I'm sorry.
I know it sounds silly. Like I know we gauge our muscle strength based on the scale of 0 to is it 5 or 6? But
5, yeah.
5. Is there a way for our high tone? Is there a scale for a high tone?
No, there's not that I'm aware.
Mild, moderate, or okay.
No, there isn't. I mean, that's again that tester experience, and it's
Right.
more, depending on rater. Yeah. Does that answer your
I
question?
see that Dr.
Yeah.
Bayat has her hand up.
Thank you.
Hi, good morning. Thank you so much for the talk and for taking such good care of our patients. I have a quick question. I'm one of the family planning providers, so we do a lot of office-based procedures that can be quite uncomfortable for the patient, including office aspirations or IUDs, things like that. I'm wondering if you have maybe any pearls or anything you've learned through your experience about things that we can do as a provider that might make the pelvic exam less uncomfortable or traumatic for patients who in general are intolerant of exams.
Okay.
Thank you.
Right. Thank you for that question. It's a good question. I mean, we encounter this situation all the time. People are not like happily walking into it. Nobody wants to go through it. I feel that this is my take on it, again, subjective and with my experiences, is once you explain what you're going to do, walk them through as you're doing it, takes the fear away. Remember, fear comes from not having control over the situation, right? So your job as a practitioner is to give them that control, make sure that they have control over the situation. And that control comes on when you explain them, this is what I'm going to do. I literally take the model of pelvic floor and show them, this is how I'm going to go in, this is how I'm going to proceed, and I'm going to talk to you every time I'm doing something. So that alone makes them comfortable a little bit. Second thing is the reason why you're doing it, just explaining them, like, if I do this, I'm going to get this, this, and this out of it, versus if I don't do it, then I'm not going to get these data points. So once you explain them the reason and an indication of your pelvic exam, I think they'll be a little relaxed. Second thing is, we had last Friday, I think we had a great lecture on trauma-informed care. And I just treat all my patients as if I'm treating patients with trauma. I usually be very gentle, very informative, making them comfortable. I think that aspect of it, instead of rushing through it, that makes them, it's anticipation of pain and not pain itself that makes them all, tight and unrelaxed. So I'll approach them from that standard too. I would work on their dignity, making sure that they're covered, they're comfortable. The room is, mildly lit. There are not many noises around. People are not walking by. All these things, however minor, make a huge difference in their participation. And then finally, if they have, like, if you're going in with the speculum, if you're kind of reaching in, I would definitely kind of have them do deep breathing. We talked about the sympathetic and parasympathetic response. Their sympathetic response is like through the roof at that point. So your job is to then bring that down by using deep breathing exercises. Your safe touch, just putting your hands on their hand, making sure that you got it, you understand what they're going to go through now. And your body language also plays a role. So I think all that put together would be good. I mean, it'd be nice to like have them lay there a little bit, 5-10 minutes, or even a couple minutes, and leave the room so that they can understand what's going on. I think all those little things play a big part. I don't know if that helps.
There is, this is Nancy again.
Okay.
Dee Hartman, I know you mentioned one of the papers that she co-authored, and I don't know if you know Dee Hartman.
No.
She's a huge pelvic floor physical therapist, very well known.
Mm-hmm.
He has a YouTube video, and I have a printed sheet of, and I'm sure for Ashwini, this is something you do routinely. But it's 5 exercises to do before vaginal penetration.
Mm-hmm.
It's a combination of, like you said, deep breathing. You do some bridging. There's like the knee to elbow, knee to shoulder. And it's a combination of 5 exercises that help kind of relax the muscles a little bit and focus on deep breathing. So it puts it all together. And I give that handout in the YouTube site to my patients if they're going to use dilators at home or before they're going to try to have intercourse. And even sometimes while there's a wait for pelvic floor physical therapy, I'll give them a couple websites that they can go to that just kind of explain the pelvic floor, hoping by the time they get to you, they have a little bit of understanding what's happening. So
I think
that
yeah.
little 5-minute stretch might be a good idea.
Right before the
Patients,
they
yeah.
have an IUD placement, yes.
Yeah, but I
So
think
that-
certainly the breathing is really important and the
right.
explaining and taking your time.
Right. I mean, thank you for reminding me that. I'm completely missed out on that topic because, I'm just thinking about like your office or your office-based medical interventions, but you can always, the exercise, since you brought my attention back to the exercises, and I didn't put any exercises in here because I felt that it's pretty, individualized approach instead of like just blanketly do this, but for pelvic pain or apprehension of any insertion, the ones that definitely work is they definitely need to do deep breathing exercises. That's given. The butterfly stretch, like having your feet together and dropping your knees, like opening your legs sort of away, so that's a better butterfly stretch. That's a pretty good stretch that people can do before any office procedures. They could do happy baby stretch where they can literally bring their knees with their hips abducted, like knees bent, hip abducted, and flex towards their chest. They can do figure 4 stretch, like a piriformis stretch. Piriformis is like the larger muscle in your hip area, and that kind of, if you stretch that, your pelvic floor kind of down trains a little bit. So I think that's a good approach that you can do in the office setting. The other thing I wanted to point out that you brought up, okay, YouTube. So YouTube has a lot of resources, and sometimes it could be misleading for the patients, but I have my favorites too that I send the link to the patient or I run them while they are here with me. So thank you for that insight.
Oh, thank you. If you can share those sites, that would be great.
Oh, absolutely.
That'd be great for the consistency.
Yes, and I'll also put together a list of acupuncturists in the area who take insurance. So that'd be another thing that we could do for these patients.
Oh, that's amazing. Thank you.
No problem.
I see that Dr. Sharma has her hand up.
Okay.
Thanks, Ashwini, for all the information.
Okay.
My name is Ruchira Sharma. I'm one of the maternal fetal medicine doctors. I had a question about patients who've had operative vaginal deliveries and have had advanced perineal tears, so grade 3 or 4, and they have sphincter healing issues. When's the ideal time to send them to you? Would that still be 6 to 8 weeks, or would you like to see them maybe later?
So wound healing is important. If they're not healed, if the wound is open, which is unlikely at that time, but if the wound is still healing, open, they're in severe pain, obviously I would wait a little bit. But the guideline is 6 to 8 weeks. If they're fully healed, like this, there's no opening in the skin, I would definitely like to see them sooner than later. These people will present with like frank fecal incontinence, like they're just like losing it. Fecal incontinence, urinary incontinence, and PT definitely does wonders. Like within 1 or 2 weeks, we'll start seeing the difference, huge amount of difference. So definitely, if the skin is open, hold them. If the skin is all closed, send them over.
Thank you.
You're welcome.
All right, well, thank you so much for this amazing review. We very much appreciate it.
No problem. Thank you for inviting me.
All right, so we'll conclude here, and I wish everyone a fulfilling and successful day.
I just want to, lastly, I forgot to mention that I'm going to send, Michelle is going to send a SurveyMonkey link for course evaluation. I think my school needs it. And there are some simple questions to answer. These are like yes or no questions. So if you don't mind, please fill that out. It'll just greatly help me. Thank you very much for inviting me again.
Thank you.
Thank you so much. That was great.
Thank you.
Yeah, so I had a room first. Then you go and do it.